All right, guys. So thanks for joining me. This is going to be fairly informal. Just going to do a nice review of the neurocutaneous syndromes or phakomatoses. So if you have any questions at any point, just let me know. Feel free to speak up. Like I said, it's going to be fairly informal. I could get my slides to work, which they don't seem to want to do. We'll just hold on one second. There we go. No financial disclosures. There are a fair number of cases that show images from StatDX, Radiopedia, as well as some case reports, just due to the rarity of some of these entities. So just a heads up on that. So what are we going to do? We're going to describe what constitutes a phakomatosis. We're going to review the common phakomatoses and the radiological features, review some of the less common phakomatoses, and then do a quick quiz at the end. What is a phakomatosis? Phakomatoses are a group of congenital syndromes characterized by the presence of cutaneous and CNS abnormalities, aka neurocutaneous syndromes. Comes from the Greek word phako, which, if you've ever seen Dr. Smearnitopoulos talk, know he would insert his Greek word. They're typically the result of abnormalities within the embryonic ectoderm, so skin, CNS. However, other systems can be affected and result in a broad clinical spectrum of disease. The more common phakomatoses, these aren't terribly common, and we'll go through the incidents. Neurofibromatosis type 1 and 2, tuberous sclerosis, encephalotrigeminal angiomatosis, more commonly known as Sturge-Weber, and retinocerebellar angiomatosis, more commonly known as VHL or von Hippel-Lindau. So the first and most common phakomatosis is neurofibromatosis type 1. It's an autosomal dominant inheritance in half of cases and spontaneous mutation in the other half. There's variable expression, but 100% penetrance. The mutation involves the NF1 gene, which is a tumor suppressor, which the mutation actually turns off the gene, allowing dysregulated growth, and is located on chromosome 17, Q11.2. There are diagnostic criteria, of which you require greater than 2 of the following features. So greater than 2 neurofibromas or 1 plexiform neurofibroma, optic pathway gliomas, distinctive osseous lesions, which includes wing dysplasia, thinning of the long bones, and pseudoarthroses, greater than 6 cafe au lait spots, axillary or inguinal freckling, greater than 2 iris hamartomas or lesion nodules, or a primary relative with NF1. So what are some of the imaging features, or what constitutes the syndrome? Neurofibromas, they can be localized, diffuse, or plexiform. The localized form is typically well-defined, circumscribed T2 hyperintense mass, often has a target sign with central lower signal. You can sometimes see a fascicular sign, which is low signal intensity foci representing the fascicular bundles coursing through the lesion. And they typically have variable but homogeneous enhancement. Here's an example of a localized neurofibroma arising from one of the lumbar nerve roots. So you can see this is the typical target sign, T2 hyperintense peripherally, centrally hypointense, central enhancement, and a well-defined lesion. The diffuse neurofibromas look quite a bit different. They're often T1 isointense and T2 hyperintense, ill-defined, often involve the cutaneous and subcutaneous tissues, adjacent muscles, and typically demonstrate avid enhancement. So these are very, very different from your localized neurofibromas. They are transspatial, very irregular and ill-defined, often have homogeneous enhancement within. And then your plexiform neurofibromas, which are almost diagnostic. T1 isointense to muscle, hyperintense, lobulated and follow the course of major peripheral nerves. They're often transspatial as well and demonstrate heterogeneous enhancement. This is your prototypical plexiform neurofibroma. They often refer to it as a bag of worms appearance. All these multiple lobulated tumors along the distribution, in this case, of the trigeminal nerve. Other CNS manifestations very commonly, and especially if you've been over at Mumsy, you're often following these patients for their optic pathway gliomas, which constitutes enlargement of the optic nerve, nerve sheath, chiasm, or optic radiations. It's typically T1 iso to hypointense, T2 hyperintense, and demonstrate variable enhancement. They also have foci of abnormal signal intensity, or phases, which are high T2 foci within the white matter, often in globus pallidus as well, dentate, thalami, hippocampus, and brainstem. And then they typically will have associated sphenoid wing dysplasia. So here's one of our cases showing basically the typical features of NF1. So this patient has bilateral optic pathway gliomas. You can see enlargement of the optic nerve, heterogeneous with areas of high T2 signal, which demonstrate enhancement. Enlargement of the optic nerve sheath complex as well. The patient also has a diffuse neurofibroma involving the left orbit and temporalis muscle. There are foci of abnormal signal intensity within the cerebral white matter, and the patient also has evidence of sphenoid wing dysplasia. Other CNS manifestations, they do have an increased incidence of CNS gliomas and spinal cord astrocytomas, although not a common feature. They can present with cranial nerve schwannomas, so cranial nerve palsies, vascular dysplasias, typically moya, lateral thoracic meningoceles, foraminal widening, scoliosis, and dural ectasia. So here's an example of an abducens nerve schwannoma in a neurofibromatosis type 1 patient. You can actually see evidence of lateral rectus atrophy as well. Here's just a typical example of moya. We have occlusion of the supraclinoid ICA with multiple collaterals, and then your typical lateral thoracic meningocele. And again, multiple peripheral nerve neurofibromas in the brachial plexus bilaterally. Other non-neural findings, they typically get thinning of long bone cortex with bowing of the long bones and pseudoarthroses. They can get cutaneous neurofibromas and iris hamartomas or Lisch nodules. What might we see on radiographs? In pediatrics, you get bowing of the long bones. This patient had an associated fracture with pseudoarthrosis. And then often we'll see these small soft tissue nodules, multiple, well-defined in keeping with the cutaneous neurofibromas. It's just an example in case someone actually happens to see a patient with NF1 of the Lisch nodules or iris hamartomas, typically small, well-defined lesions on the iris. Any questions on NF1 before we move on? Right, like I said, interrupt me anytime if someone does have a question. Next on the list is NF2. It's colloquially known as MISME or multiple inherited schwannomas, meningiomas, and ependymomas, which makes it nice and easy to remember. It's an autosomal dominant inheritance due to mutation in the NF2 gene on chromosome 22. It's a 22q12 deletion, resulting in inactivation of the Merlin protein. Although it is autosomal dominant, about half cases, again, are de novo mutations. Prevalence is about 1 in 50,000, so quite uncommon, and the average age of diagnosis is in the early 20s. Typical presentation is sensory neural hearing loss due to the vestibular schwannomas. It's about half of patients. And the diagnostic criteria includes bilateral vestibular schwannomas or a unilateral vestibular schwannoma with a first-degree relative with NF2, or a first-degree relative with 2 of either meningioma, schwannomas, neurofibromas, gliomas, juvenile posterior sublenticular opacities, or juvenile cataract. And since we're not ophthalmologists, just a quick diagram showing what that actually is. This is your typical cataract where your actual lens nucleus becomes cloudy. The juvenile or posterior subcapsular cataracts are actually opacities at the posterior aspect, just posterior to the substance of the lens. So our imaging findings for the neuroperspective vestibular schwannomas, when small, they're typically round or ovoid masses along the course of the vestibular nerves, typically within the interauditory canals. When larger, they fill the IAC and extend into the CP angle cisterns, resulting in the typical ice cream cone shape. They can result in bony remodeling and widening of the IAC, which can be a clue on CT. Smaller lesions typically demonstrate homogeneous signal intensity and homogeneous enhancement, and then larger lesions often become more heterogeneous with intrinsic cystic spaces. And it's important to always look for mass effect on the adjacent structures, pons, cerebellar peduncle, and other cranial nerves. This is our typical NF2 patient with bilateral small vestibular schwannomas. You can see they're quite homogeneous on T2, filling the fundus of the IAC. And then on post-contrast images, they enhance homogeneously. Then when they become larger, they become symptomatic and problematic and quite heterogeneous. So here's large conical-shaped bilateral vestibular schwannomas. There are some cystic spaces within which demonstrate no enhancement, and then you get significant mass effect on the pons, cerebellar peduncle, sorry, and you can have mass effect on the adjacent cranial nerves as well. Meningiomas, the intracranial meningiomas, there's nothing special about them except they tend to be multiple. They're extraaxial lesions, broad dural base, typically show avid enhancement. Enhancement within the dural base, associated hyperostosis, can have calcification within. Some of them can restrict diffusion. Again, nothing specific or special about them. This is our typical NF2 patient again. We've got a meningioma rising along the dorsal aspect of the clivus, extending into the IAC. There's actually a small, you can make out vestibular schwannoma as well. And the patient has a large cranial nerve 5 schwannoma as well. Again, another typical patient, bilateral vestibular schwannomas, small on the right, larger and conical on the left, and then multiple meningiomas. Within the spine, meningiomas tend to be intradural extramedullary lesions, which are more common in the thoracic spine but can occur anywhere. They can also present as nodular studding throughout the thecal sac. They're disproportionately symptomatic because they grow in a small space. So due to cord compression and mass effect, they present with myelopathic changes. Typically T1 iso to hypointense, T2 variable, often somewhat heterogeneous, and typically enhance avidly and uniformly. And again, same features as intracranial. They often have enhancing dural tails. Here's an example of a cervical meningioma, avid enhancement, extramedullary intradural lesion with a small dural tail. The schwannomas in the spine, they're typically intradural extramedullary lesions, but they can extend via nerve roots to involve the intramedullary space. Rarely they arise primarily intramedullary. They can extend extradural along the nerve roots as the typical dumbbell lesions, and often see multiple small lesions along the cauda equina. They're well-defined, intermediate T1, hyperintense T2 with intense enhancement, but when large, like all the other lesions, can demonstrate inhomogeneity, cystic degeneration, and calcification. So here's our typical cauda equina in an NF2 patient, multiple studded little T2 hypointense, in this case, enhancing lesions along the cauda equina. Bilateral schwannomas exiting nerve roots of the cervical spine, another NF2 patient, and multiple well-defined schwannomas along the brachial plexus. Ependymomas, they're the least common, but again, high association in NF2. Intramedullary lesions, most commonly in the cervical cord and at the conus. They're T1 iso to slightly hyperintense, and T2, they're centrally located hyperintense lesions with cord expansion. They typically enhance avidly on post-gadolinium images. So a few cervical cord ependymomas, T2 hyperintense, associated cord expansion. We do have some adjacent high T2 signal change. Demonstrate significant enhancement on post-contrast images. This is not actually a brainstem lesion. That's a CP angle lesion. It's vestibular schwannoma that's actually causing some mass effect. Other potential imaging findings, they do have a higher incidence of gliomas. They can have extensive intracranial calcifications in the choroid plexus, the ependyma, the ventricles, and in the cortex. And apparently 50% present with subcortical hyperintensities, which kind of look like almost like tubers. But apparently, if you look hard enough, you can find these in about 50% of NF2 patients. No associated mass effect, just hyperintense. Just checking the chat. Any questions on NF1 or NF2? And we're trying to sort of plow through here to get through on time, but everyone's happy. All right, moving on to TS. Again, if you're over at Mumsy, you see a fair number of these that get followed. It's a congenital syndrome characterized by the development of multiple hamartomas. They're typically CNS, skin, kidney, and bone. They have two distinct gene loci. There's TSC1, which is on chromosome 9, encoding hamartin, and TSC2, which is on chromosome 16, which codes for tuberin. And TSC2 is the most common and severe type with higher association of SEGAs and symptomatic seizures. About 1/3 of cases are familial, the rest are spontaneous mutations, and it is autosomal dominant with high penetrance. The incidence is 1 in 10,000, so it's a fairly common one behind NF1. And they often present with the typical cutaneous findings, seizures, and developmental delay. Diagnostic criteria, again, a lot of these are quite long lists, but you need 2 major findings for definite TS or 1 major and 1 minor finding for probable TS. The major findings are the presence of a CNS tuber, subependymal nodules, subependymal giant cell astrocytomas, cardiac rhabdomyomas, renal angiomyolipomas, lymphangiomyomatosis or LAM, adenoma sebaceum, subungual or periungual fibromas, hypomelanotic macules, shagreen patches, or retinal hamartomas. So 4 of these we see often on CNS imaging. Then the minor criteria are white matter lesions, dental pits, gingival fibromas, rectal polyps, bone cysts, non-renal hamartomas, retinal achromal patches, confetti skin lesions, and multiple renal cysts. So again, we often will see the white matter lesions on CNS imaging. A few of the clinical findings. So here's your subungual fibroma. Again, just enlargement just below the nail. Adenoma sebaceum. This is our hypomelanotic macule. As just a renal lesion, which we'll get to those later. So our CNS findings, tubers, subependymal nodules, and SEGAs. The cortical tubers, when supratentorial, they're typically cortical and subcortical in location, expansile, T2 and flare hyperintense, often with radial migration lines towards the ventricles. They're T1 hyperintense prior to myelination and hypointense after myelination. They may calcify, and some of them demonstrate some very faint enhancement as well. Cerebellar tumors are more wedge-shaped. They're areas of volume loss and distortion of the folia. Enhancement's quite common infratentorially, and they can occasionally calcify. So here's our typical appearance for a TS patient on flare. We've got multiple cortical tubers, as you can see, and then right frontal lobe, we have radial migration lines extending towards the ventricular surface. Our subependymal nodules, the distribution typically follows the fetal germinal matrix. So caudothalamic groove is the most common location, followed by ventricular body and atria, and then temporal horns. They often calcify, so become easily visible on SWI and CT, and they're typically slightly T1 hyperintense, T2 hyperintense, and flare hyperintense, and usually enhance. Here's an example of a couple small subependymal nodules. We've got one little one in the atrium and one at the caudothalamic groove. These differ slightly from subependymal giant cell astrocytomas, which are actually a slow-growing leoneuronal tumor, WHO grade 1. They're essentially isolated to patients with tuberous sclerosis. So if you have a diagnosis of a SEGA in someone who doesn't have a diagnosis of tuberous sclerosis, look really hard for another major or minor feature. They originate at the foramen of Monroe. They're enhancing and enlarging masses, typically greater than 1.2 centimeters. It's always going to be a SEGA. They have variable calcifications. T1 hypointense, heterogeneous on T2, and flare hyperintense with inhomogeneous but typically avid enhancement. And because of their location, they often will present with hydrocephalus as a result. So again, a large mass. This patient has bilateral masses centered at the foramen of Monroe, avidly enhancing, presence of multiple subependymal nodules. This is a tuber that partially demonstrates low-level enhancement within, and then multiple additional tubers on the flare we can see on the left side. Other findings, some of these we may actually run into when you're doing spine imaging. So renal angiomyolipomas are very common. Lymphangioliomyomatosis and multifocal micronodular pneumocyte hyperplasia are findings within the lungs. We get cardiac rhabdomyomas, which are often spontaneously resolving, retinal hamartomas, and sclerotic bone islands and bone cysts, as well as hyperostosis. So renal angiomyolipomas, most common benign renal neoplasms, and 80% of TS patients have them, but 90% of AMLs are in patients who do not have TS. But if you do see multiple bilateral, think about tuberous sclerosis and start looking for other stigmata. The cortically based renal masses containing macroscopic fat can hemorrhage, and the risk of this increases with size. So anything over 4 centimeters has a high incidence. They can be associated with renal artery aneurysms as well, which increases the risk of hemorrhage as well. And always be aware, make sure you're looking at all the renal lesions because there is a higher incidence of renal cell carcinoma in tuberous sclerosis patients. It's your typical AML on ultrasound, hyperechoic lesion, well-defined within the cortex, and typical appearance on CT, again, macroscopic fat within multiple bilateral. And typical features on MR. So again, they're iso intense on T1 to fat. They will suppress. And then this is in and out of phase imaging, demonstrating the presence of macroscopic fat. Within the lungs, we see it on CTA carotid, perhaps. Lymphangioliomyomatosis, or LAM, which is a progressive cystic lung disease, where they get diffuse bilateral thin-walled cyst and propensity to pneumothoraces and chylothoraces. This can coexist or be isolated from multifocal micronodular pneumocyte hyperplasia, which is multiple small non-calcified pulmonary nodules. It's an example from StatDX of multiple cysts as well as multiple small nodules, coexistent LAM and multifocal multinodular pneumocyte hyperplasia. Again, a very advanced case of LAM in a TS patient. This is less likely for us to see, but important nonetheless. Cardiac rhabdomyomas, 100% of patients with multiple and approximately 50% of patients with solitary rhabdomyomas have TS. Can often be diagnosed on prenatal and antenatal echocardiography and shows as a well-defined hyperechoic mass or masses. MR demonstrates T2 bright, T1 iso intense, and slightly T1 iso to slightly hyperintense, well-defined myocardial mass. They can also appear as just focal wall thickening or a mass protruding into the lumen. And here it is on echo. So well-defined lesion, the right ventricular apex. And here's one in the left ventricle on MRI. Again, well-defined lesion within the wall. These often involute on their own and just become areas of myocardial fat. Retinal hamartomas, if you're really lucky and really astute, you can actually pick these up on CT and MRI. CT, you may see calcifications within larger optic drusen. On MRI, you can look for areas of nodular thickening of the retina. So there's an example here, just very subtle areas of nodular thickening of the retina. Again, it takes a very keen eye to actually see that. Again, multiple sclerotic bone lesions and bone cysts. So they are typically bone islands. We'll see these often on CT and MRI. Again, nothing special about them, just multiplicity. Think TS. And then they often get hypertrophic osteoarthropathy as well. So basically just benign proliferation of the periosteum. Any questions on TS? Right, moving right along. Sturge-Weber syndrome or encephalotrigeminal angiomatosis. This is a congenital but not inherited syndrome due to a spontaneous mutation in the GNAC gene on chromosome 9. Incidence is about 1 in 20 to 50,000. And basically, it involves abnormal cortical venous development. You get progressive venous occlusion, recruitment of alternative venous pathways, and chronic venous ischemia. About 95% have facial capillary malformations, which are characteristic through the port wine stain. And they typically present with seizures, which can progress to hemiparesis and stroke-like episodes. And the seizures typically present very young in the first year or so. This is the typical cutaneous manifestation. So this is the port wine stain, dark facial capillary malformation, typical of Sturge-Weber. On imaging, CT, we often see tram tract cortical calcification, ipsilateral parenchymal atrophy, calvarial thickening and hyperpneumatization of the ipsilateral paranasal sinuses or mastoids owing to brain atrophy, almost like a Davidoff-Mason. You get ipsilateral choroid plexus enlargement and gyral enhancement on CT. MRI shows accelerated myelination in the young with decreased T2 signaling in the cortex and subcortical white matter due to calcium. You'll get gliosis in advanced stages, and SWI will show dilated venous collaterals and calcifications, typically normal on DWI unless you happen to catch it during a time of acute venous ischemia. You'll get extensive leptomeningeal enhancement and choroidal globe enhancement as well. So here's an example with the tram tract calcification on CT. This patient happened to have a large choroid plexus meningioma as well, which is a little bit distracting. You can see the extensive calcification, typical of Sturge-Weber. On MRI in the same patient, we get cortical low signal, in keeping with the areas of calcification. There are areas of extensive leptomeningeal enhancement as well. There are also areas of gliosis. It's tough to discern on this patient, however, whether that's edema from the adjacent mass or gliosis itself. A case from the literature, again, calcification, subcortical and cortical. This one is affecting the bilateral frontal lobes, extensive atrophy as well. And then we have extensive leptomeningeal enhancement in this patient with prominent penile draining vein, just representing the collateral venous drainage pathways. And then you can see there's extensive ipsilateral cortical atrophy with dilation of the left lateral ventricle. Any questions on Sturge-Weber? It's a more isolated syndrome just to the brain, face, and eye. Right, moving right along. Von Hippel-Lindau, or retinocerebellar angiomatosis. It's a syndrome of hemangioblastomas, renal cell carcinomas, cystadenomas, and pheochromocytomas. Autosomal dominant inheritance with mutation on the VHL tumor suppressor gene on chromosome 3. Incidence is similar to that of Sturge-Weber at 30,000 to 50,000. Commonly presents with visual symptoms in the teens due to the presence of retinal angiomas. They'll often get retinal hemorrhages as well. Cerebellar hemangioblastomas present with headache, hydrocephalus, ataxia, your typical posterior fossa tumor symptoms. And then spinal hemangioblastomas often present with symptoms of myelopathy, can present acutely in the presence of hemorrhage as well. So the diagnostic criteria, you need 2 or more CNS hemangioblastomas or a solitary hemangioblastoma plus a visceral lesion or retinal hemorrhage. Visceral lesions are clear cell renal carcinoma, pheochromocytomas, endolymphatic sac tumors, pancreatic cysts or islet cell tumors, and epididymal cysts or cystadenomas. So our typical hemangioblastoma findings, they're present in 60 to 80% of the VHL patients. The typical appearance is a cystic cerebellar mass with an enhancing nodule. Looks just like your pilocytic astrocytoma in peds, typically a little bit older age group. Approximately 1/3 will show only a solid enhancing mass. On MRI, they're typically T2 iso to hypointense nodule with flavoids. T2, the nodule is hyperintense, again with flavoids. They can have areas of T2 hypointensity and blooming due to hemorrhage, often flare hyperintense within the cyst, plus or minus adjacent edema, and intense enhancement of the solid component with no enhancement of the wall. So again, here's our typical cerebellar hemangioblastoma. We have a flare here with flare hyperintense nodule, slightly flared hyperintense fluid within, no diffusion restriction, and then avidly enhancing nodule with no enhancement of the cyst. And then this patient presented with hydrocephalus due to the mass effect. This is the less typical appearance. This patient has multiple enhancing solid nodules within the posterior fossa, which were path-proven hemangioblastomas as well. Another presentation, again, a cyst with a smaller solid component, smaller enhancing solid component, but more prominent adjacent edema. So they can have a slightly variable appearance. But if you see a posterior fossa mass in a younger patient that avidly or has avidly enhancing components or cystic space, definitely think hemangioblastoma. Our spinal hemangioblastomas, again, have a somewhat similar appearance. They typically present with an enhancing nodule. They'll often be associated with cord edema and expansion. They can involve the cauda equina as well along the nerve roots. On T2, look for areas of low signal intensity centrally, which can indicate areas of hemorrhage. Another thing to always have a look at when you're looking at VHL patients on brain MRI or CT is cystadenoma of the endolymphatic sac or endolymphatic sac tumors. On CT, these typically show as permeative destructive lesions of the petrous temporal bone. T1, they're heterogeneous. T2 and flare, hyperintense, and demonstrate heterogeneous enhancement. This is the typical CT appearance. Again, we have a permeative destructive lesion within the petrous temporal bone, some extension into the middle ear and mastoid ear cells. T1, you get heterogeneous areas of T1 hyperintensity and hypointensity within. T2, again, quite heterogeneous. Sorry, this is a post-gadolinium enhanced image with heterogeneous avid enhancement. And then T2, heterogeneous appearance with occasional hematocrit levels as well, indicative of intrinsic hemorrhage. Other findings, again, when we're looking at the spine, always look at the kidneys or what you can see of the kidneys. They'll often have renal cysts, and about 25 to 40% of VHL patients will develop clear cell renal cell carcinoma. So definitely always inspect vigorously any renal cyst or any renal lesion that you see. The pancreas, they get cysts, serous adenomas, and neuroendocrine tumors. So again, there is usually a good amount of pancreas available for us in the field of view in the spine. So always interrogate that very, very well. They do get pheochromocytomas and cystadenomas of the epididymis. Can have cystadenomas of the broad ligament as well in females, but it's much less common. So this is our typical spinal MRI. Again, we do see multiple pancreatic cysts. This is obviously the same patient, but a dedicated abdominal MRI with multiple renal cysts and pancreatic cysts. And then we have some complex renal cysts, clear cell renal cell carcinoma on this one. So just always be vigilant. More typical appearance of the clear cell renal cell carcinomas, so avidly enhancing areas of peripheral enhancement, central necrosis, and bilateral lesions as well. Not uncommon in VHL patients. Again, multiple pancreatic cysts and serous cystadenoma, and always look for any avidly enhancing lesions which could indicate neuroendocrine tumors or islet cell tumors. And this is our typical sonographic appearance of a cystadenoma of the epididymis, somewhat complex lesion within the epididymal head, multiple cystic spaces. Any questions on the more common phakomatoses before we do an even quicker run through a bunch of the uncommon phakomatoses? Right? Everyone can hear me though? Not talking into the ether?
Yeah, we can.
Okay, perfect. Okay, so there are a bunch of uncommon neurocutaneous syndromes that we do very occasionally run into, or at least we'll see on requisitions questioning whether these are present. So we'll just basically list them off, try to list off the findings, and try to get through them all within the hour. One of the more common ones is basal cell nevus syndrome or Gorlin syndrome. It's also known as Gorlin-Golt syndrome or nevoid basal cell carcinoma syndrome. That's approximately 1 in 60,000. It's a mutation in the PTCH tumor suppressor gene on chromosome 9, which encodes Sonic the Hedgehog. Someone was a big Sega fan when this came out. About 50% are de novo mutations, the rest are inherited. And it's characterized by odontogenic keratocysts, multiple basal cell carcinomas, craniofacial and MSK anomalies, as well as increased risk of malignancy and hamartomas. There are, again, diagnostic criteria. Two or more major or one major and one minor criteria will result in diagnosis of basal cell nevus syndrome. The major are 2 basal cell carcinomas, or 1 under the age of 20, the presence of odontogenic keratocysts, palmar pits, calcification of the falx, which is bilamellar and has a somewhat typical appearance, rib anomalies like bifid ribs or fused ribs, or a first-degree relative with it. And then the minor diagnostic criteria are macrocephaly, frontal bossing, cleft lip, hypertelorism, Sprengel deformity, pectus excavatum or carinatum, syndactyly, bridging of the sella, hemivertebra, flame-shaped osseous lucencies, ovarian fibromas, or medulloblastomas. So as far as the CNS goes, the increased risk of medulloblastoma is the one thing that we really want to look out for. It's a male to female predominance. Develops in fair number of basal cell nevus syndromes patients, up to 20%. Head and neck findings will often see the odontogenic keratocysts, which are present in 80 to 90% of patients with the syndrome. You can see frontal bossing and macrocephaly, and then you get calcification of the falx tentorium, petroclinoid ligaments. If you're really astute and looking for it, you can see hypertelorism and bridging of the sella. They will occasionally have agenesis of the corpus callosum and a high arch palate. So our odontogenic keratocysts are sharply marginated lucencies surrounding unerupted teeth. They have a very characteristic appearance. Medulloblastomas in basal cell nevus syndrome typically are not the pediatric kind. They're desmoplastic, which are off midline. They do demonstrate similar appearance or similar characteristics to the midline pediatric medulloblastomas, where they enhance avidly and avidly restrict diffusion, and they are still WHO grade 4 lesions. There are 2 mutations. There's PTCH1 and SUFU mutation, of which the SUFU mutation is highly associated with medulloblastomas. And then we'll often see dural and falcine calcification. So here's an example of an odontogenic keratocyst. I don't have the unerupted tooth in this slice. I apologize for that, but it is a well-defined lucent lesion within the mandible. Can have obviously definite bony thinning as well. And here's the bilamellar dural calcification, so along the falx, both sides, and along the pachymeninges, bilateral cerebral hemispheres. And here's our typical T2 appearance of a desmoplastic medulloblastoma, so solid mass, a little bit T2 iso to hypo-intense, with some cystic spaces within. Would restrict diffusion, has associated edema and mass effect. Non-neuro or head and neck findings: shortened fourth metacarpals, rib anomalies, pulmonar plantar pitting, calcified ovarian fibromas, cardiac fibromas, fetal rhabdomyomas, and lymphomesenteric cysts. These aren't ones that we will run into all that often on neuroimaging, but just important to be aware of. This patient with basal nevus syndrome with multiple basal cell carcinomas, small, and then palmar pitting as well, just to see what that looks like. Any questions on that one? Okay, Wyburn-Mason syndrome. This is a congenital non-hereditary syndrome caused by causing unilateral vascular malformations of the face, orbit, and brain. That's also classified as one of the cerebrofacial arteriovenous metameric syndromes. There are less than 100 cases described as of 2024, so quite uncommon. You get intracranial AVMs, which tend to be located in the midbrain and diencephalon, ipsilateral to a vascular malformation of the face and orbit. Here's an example of Wyburn-Mason. We have a large vascular malformation involving the right hemiface with innumerable serpiginous flavoids extending bilaterally. And then we have an ipsilateral arteriovenous malformation involving the diencephalon, right midbrain. Very uncommon, but again, if you have someone with a facial vascular malformation, then realize that there's an AVM in the perimesencephalic cistern or in the midbrain. You may get the 101st case report. So, ataxia telangiectasia. So another autosomal, an autosomal recessive due to a mutation in the ataxia telangiectasia mutated gene. The incidence of this is more common about 1 in 40 to 100,000. You get progressive atrophy beginning in the cerebral vermis, then moving to the cerebellar hemispheres, then peduncles. And you can have associated telangiectasias, which may show as blooming on SWI or a faint blush of contrast. They'll typically present clinically with mucocutaneous telangiectasias present early in life, and they do carry an increased risk of malignancy, lymphoma and leukemia in pediatric populations, and breast and gastric, typically in adult populations. So here are typical progressed findings. This looks like your typical atrophy, except you realize it's a 19-year-old male. So extensive cerebellar atrophy. The vermis isn't well shown in this, but is quite atrophic. And then the cerebellar peduncles in this patient are also quite atrophic. And this is serial, so 18 months on the left and 4.5 years on the right. So when you realize this is a 4.5-year-old, that's quite extensive cerebellar vermian atrophy. And then when you look at it over the span of the 3 years, that's quite striking as well. And this is the typical presence of telangiectasia on SWI. So you get this little area. It's not necessarily blooming artifact, but it's low susceptibility signal. And they typically will show this blush of sort of ill-defined low-level enhancement. Any questions on the two vascular or the more vascular phakomatoses? Right. Perry-Romberg syndrome. So this is another rare phakomatosis with unilateral progressive facial atrophy. Typically involves the skin, then underlying fat and muscle, cartilage, and bone. Can involve the underlying brain, typically the ipsilateral hemisphere. You get atrophy, calcifications, white matter signal abnormalities, corpus callosum infarcts, microhemorrhages, and leptomeningeal enhancement. This is an example of a patient with Perry-Romberg. You actually have loss of the calvarium, loss of the overlying skin, and then ipsilateral to that, you do have microhemorrhages with abnormal signal and mild atrophy, if you can appreciate the slight dilation of the left lateral ventricle. Very strange, again, not a common thing that we see. Cowden syndrome is slightly more common. It's also known as multiple hamartoma syndrome. Incidence is approximately 1 in 200,000. It's autosomal dominant inheritance caused by mutations to the PTEN tumor suppressor gene. They get cutaneous and mucosal lesions, macrocephaly, thyroid adenomas, and multinodular goiters, GI polyps, breast fibroadenomas and fibrocystic changes, lipomas, lipomatosis, testicular lipomatosis, leiomyomas, glycogenic acanthosis, multiple benign lesions. They also are associated with a higher risk of multiple malignancies. So 30 to 50% develop breast cancer, 5% develop thyroid, 5 to 10 develop endometrial, and then there's a possible link to renal cell, colorectal, and melanoma. As far as the CNS findings, our typical finding is the dysplastic cerebellar gangliocytoma or Lemitte-Dublo. It's a debate whether this is actually a neoplasm versus a hamartoma. It's characterized as WHO grade 1. On imaging, it's T1 hypointense. On T2, you get intermixed linear areas of T2 iso and hyperintensity, which gives the typical or characteristic tigroid pattern, and typically does not demonstrate any enhancement. So this is our very typical, this is the prototype, the Oski case, the Ant Mini. You get expansion and signal abnormalities in a sort of striated or tigroid pattern throughout one cerebellar hemisphere. Sorry, does have some mass effect just due to the growth, but it is very, very slow growing. Thanks, Ewan, for the case. Now getting even more rare, but another nice one with sort of typical CNS findings, Gomez-Lopez-Hernandez syndrome or cerebellar trigeminal dermal dysplasia. It's another neurocutaneous syndrome characterized by partial alopecia of the scalp, trigeminal anesthesia, and rhomboencephalosynapsis. Again, circa 2017, there were about 35 reported cases, and after that, they stopped sort of describing the number that they'd seen. So typical CNS findings that we're going to see is rhomboencephalosynapsis, basically absence of the cerebellar vermis with fusion of the cerebellar hemispheres. Can have associated supratentorial midline abnormalities such as agenesis corpus callosum, holoprosencephaly, etc., but not necessary. And then they have a typical, show you a different phakomatosis that has a similar finding, but they have a typical occipital alopecia, focal alopecia, which will appear similar to encephalocutaneous lipomatosis. So this is another rare syndrome with less than 50 cases reported of unilateral lipomas and other benign head and neck neoplasms with typically ipsilateral intracranial abnormalities. So you can get atrophy, enhancement or vascular abnormalities, intracranial lipomas, intradural spinal lipomas or lipomatosis, migrational anomalies and polymicrogyria, ventricular enlargement, intracranial cysts, cortical calcifications, often very early on in life. They're often associated with expansion of the calvarium or calvario defects, and you can have scleral or orbital chorostomas. The characteristic clinical finding in this is nevus siloliparus, which is focal alopecia overlying a lipomatous mass. Patients often present with infantile seizures, and they're also prone to coarctation of the aorta, benign osteomas of the jaw. So this is the nevus siloliparus. So basically you have an area of focal alopecia. In this case, there is an underlying lipomatous mass. In Gomez-Lopez-Hernandez, there would not be an associated lipomatous mass. They'll have intracranial lipomas, extracranial lipomas. Again, extracranial lipomas, cranial defects, ipsilateral atrophy with enlargement of the lateral ventricle. Very broad spectrum of what you can actually see. This is an intradural and intracranial lipoma, very large, associated cerebellar malformation, multiple intracranial lipomas. Again, very broad spectrum of disease. And the last one we're going to go through, which I think will actually finish on time, is Faces syndrome. So this is the presence of an infantile hemangioma plus one or more of posterior fossa malformations. Hemangioma, the hemangioma is in there. Arterial lesions such as aberrant subclavian, coarctation, aneurysms, anomalous course of branching of the vessels. They have persistent anastomoses or ICA steno-occlusive disease. They often have cardiac abnormalities, including VSDs, ASDs, PDAs, pulmonary stenosis, and aortic stenosis. They'll have ocular abnormalities, including microphthalmos, optic nerve hypoplasia, and colobomas, and then sternal defects or supraumbilical rapes. The typical clinical diagnosis of exclusion or differential diagnosis is Sturge-Weber syndrome due to the similarities in skin findings. There's approximately a 9-to-1 female predominance, and 2/3 have a systemic vasculopathy or cardiac abnormalities. And the typical findings are an infantile hemangioma and unilateral ipsilateral cerebellar hypoplasia. So a ton of possible brain findings. So again, cerebellar hypoplasia, prominent retrocerebellar space or Dandy-Walker spectrum, dysgenesis of the corpus callosum, hemiatrophy or hypoplasia, malrotation of the hippocampus, migrational anomalies, heterotopia and polymicrogyria, cysts, hypoplasia or aplasia of the carotid or vertebral arteries, persistent embryonic anastomoses, or arterial tortuosity and aneurysms or vasculopathy. So this is the typical infantile hemangioma. So again, you can see how that could easily be confused for the capillary malformation in Sturge-Weber. These typically regress on their own, so a little bit more benign course as far as the hemangioma goes itself. This is a patient with a diffuse infantile hemangioma of the right hemiface and ipsilateral right cerebellar hypoplasia. Another case with ipsilateral or with cerebellar hypoplasia unilateral and some cortical calcification of the pons. Another patient with an infantile hemangioma. This one is more subtle, but there's actually agenesis of the left carotid. And And this is another patient with a large facial hemangioma, partially genesis of the corpus callosum, and then they have multiple collateral vessels due to, I believe this one was just a tortuous azygous anterior cerebral artery. Okay, questions?
No questions, James. That was fantastic. There's a lot of information, but really
it is, yeah. I will send this out so you guys can reference it as well. I do have a few quick quiz questions. Obviously, we're not taking marks, but just for retention of hopefully some knowledge. So yeah, just you can test yourselves. Basically, have a run at it. Which phacomatoses has the highest incidence? NF2, Cowden syndrome, tuberous sclerosis, or von Hippel-Lindau? That is the highest incidence of these four. Right, everyone's got their answers. So TS of these four is about 1 in 10,000. Neurofibromatosis type 1 is the most common, but of these four, tuberous sclerosis would be the most common. So the correct answer. Which of the following does not have ocular or orbital manifestations? Tuberous sclerosis, VHL, NF1, Sturge-Weber, or NF2?
NF2?
Correct. Which of the following is not associated with subcortical T2 or flare signal changes? TS, NF2, Sturge-Weber, or Gomez-Lopez-Hernandez syndrome? Again, that one's just associated typically with rhomboencephalosynapsis as far as the CNS findings. And which neurocutaneous syndrome is most commonly associated with cystic lung disease?
TS.
Yes.
Perfect. Yeah, that's right. All right. There's something in the chat. Perfect. All right. Any questions at all? Like I said, I'll send this out so you guys can reference it. It does have some just bullet points if you're ever wondering whether you're looking at a phakomatosis that hasn't been diagnosed.
Fantastic. Thank you.
No
Thank
problem.
you so much, Doctor.
Thank you.
Thank you. Thanks for your attention, guys.